Now we've got Robert Libbey here joining us today, who's got a wealth of knowledge. He makes great courses for massage therapists and other manual therapy practitioners. Um, and I've taken his courses. They're very, very good. They're really worth looking into if you want to take some good quality courses for high level care. I'm going to let Robert explain what he is here to talk to us about and hand the stage over to you. So go ahead, Robert.
Okay, thanks. I really appreciate being here and being asked to contribute to your members. It's an honor to do this kind of stuff for everybody in the profession, and I'm happy that this is getting recorded. It's going to go into the private Facebook account, and then you guys will have access to this information. It's a quick 1 hour presentation. There's a lot of information that I'm going to be throwing at you. Some of it's going to go over top of your head. Some of it's going to be like, what did he just say? What are the words that he's using? How are we supposed to word things now? Am I not supposed to say this? Am I supposed to say that? So it's going to be great that you're going to be able to go back and watch it over and over again so that it solidifies and in sort of improves your competence and your confidence in what we do as therapists, as clinicians with our patients. This is a talk that I gave at the 2023 RMTAO, so the Registered Massage Therapy Association of Ontario, at their research conference that they had last year. This is 24, right? Okay. So for those of you that don't know me, I've been practicing for 30 years. I've taught at West Coast College for about a decade. I taught everything from general orthopedics to spinal orthopedics, neurological assessment to systemics. When I went through school in 93, 94, it was at Canadian College Massage and Hydrotherapy in Ontario. It was an amazing course at that time. It was a condensed course, so we did 2,500 hours in 18 months, and it was a full-on sprint the whole time. It was intense. We had instructors that were, medical doctors, surgeons, chiropractors, EMTs. It was just amazing. And our breast massage course. I know the breast massage course, when I taught it at West Coast College in Systemics 2, I think it was a day, maybe two at the most, and it was mostly just theory the first day, and then the next week it was, implementation of hands-on stuff. But it wasn't a whole class, it was part of a class. When we went through a Canadian college, it ended up being about a week. So we had a ton of information and research into the anatomy, physiology, neuroanatomy, vasculature, lymphatics, pathologies. And then we got to work on a number of amazing, female volunteers from our class. So we had access to various types of different breast tissues and all of that. So it's an amazing aspect of our clinical practice that I don't think is utilized enough. I don't think it's talked about enough. I know that as a male therapist, talking about it with my female patients, there's challenges in communication and narratives and all of that. But once they understand where we're coming from a very clinical, practical background and base, there's been a ton of just acceptance and openness to it, and just acknowledgement and appreciation for that the body that they have typically been sort of, them about them and don't touch them, and they're only used for one thing or two things. And so anyways,
That's
um
that's often the
so
way
that
that it
so that's
is.
me.
And I think that it's really important to move the conversation forward so that, male therapists and other people can have a safe, educated conversation and safe, educated experience. So it's not so scary for therapists to do. It's not so, intimidating for patients to receive. And the whole thing just becomes normalized. And I have to say, I'm very impressed that you got 2 days of breast massage in your course, because I got one afternoon in my class, and now they're not even teaching it in curriculum. They're like, this is too, you just need to focus on the basic clinical skills and nothing more. So it's actually getting downgraded in education, except it's something that so many people end up needing care for once they go through surgery. And so, becomes doubly as important to provide education after graduation so that people can, move into a more advanced skill set and not be intimidated by doing this work. Yeah,
It's almost as if the regulatory body is making decisions about removing, important aspects of the curriculum in order to diminish any potential risks of harm from happening, when that's not the way to go. Like, you want to reduce the risk of harm, you provide more education.
totally. Agreed. Yeah,
Yeah.
because when people don't know what they're doing, they're like, maybe I'll try this and maybe this will
Yeah.
work. And sometimes ends up being just a schmozzle, and it's not what people need.
I teach a course on thorax, on manipulating sternum and sternocondral joints and costochondral joints and pleural tissue and parietal pleural and pericardium and lung tissue, and it's all anterior thorax work. And I was teaching a group of Canadian Sports Massage Therapy Association members. So these guys, like they've gone above and beyond. They've got an additional 3 years of education and all of that goes into it. And I was teaching this, and I had a male student in the class who's, a massage therapist for 15, 18 years. And he said, I will never put my hand on the front of a female patient. I'm like, why? Like, we're treating the sternum. We're not treating breast tissue or anything. No, won't do it. No, just don't want to run the risk of getting called out. It's like, well, then educate your patient and get informed consent first and document it and check in, like treat them like a person rather than an inanimate object, right? So
Liability.
I actually forced him to put his hand onto a female student's sternum, and she was like encouraging him, like, "No, you can do this. I feel safe. It's fine." And it was only after that half day of class that he finally got a little bit more comfortable with it. But he'd been practicing for 18 years. It had never worked on anterior thorax on any of his female patients.
Mm.
Like,
It's just such an opportunity for advancement in their healing and ability to get over pain. And it's amazing how much of the front of the body affects the back of the body. And if you never attend to the front of the body, you just miss so much about how you can assist the entire body.
yeah. My question to him was, well, how do you treat, post-pleural pathologies and, infections and colds and things like that? How do you treat that stuff? He just didn't have an answer.
Just
So,
didn't, maybe. Yeah. So this is why this education is so important, because it removes the fear factor where people are like, oh, okay, this is okay. I understand there's protocols in place. This is all safe. And it's like everything's above board. It's all okay to do.
yeah,
And so advancing that, even just the conversation around it, I think is so important. Yeah.
absolutely. Okay, so this is deconstructing the neuropsychophysiological nature of joint pain. And for those of us who've been working with patients that have had various types of breast pathologies or injuries or surgeries, uh, joint pain or pain and discomfort in that anterior thorax area is a very common thing that we work with. So I'm going to give you some information that I've accumulated over my years about this. This is a talk that I did for the Registered Massage Therapy Association 2023 Understanding Pain Educational Conference. It was a 1 hour talk. It was very quick. It was, unbeknownst to me, they had put me in the big room, which was a big, huge ballroom, and it was standing room only. So it was fantastic to be there to be able to provide this information to therapists. So I've run a practice for, it says 28 years, it's actually 30 years. I need to update this. I'm biased towards evidence science-based practice. I treat from a neurocentric, biopsychosocial, biotensegral perspective. I've got online courses, books, posters that I've created. And I'm not just a clinician, I'm also a patient. because I live with chronic pain from a severe motor vehicle accident that I had about 6 years ago. So these are the courses that I teach. I've got online courses and live courses. I've written a book. I'm in the middle of going through the second edition right now. But the majority of the information I provide in this talk is covered in the book. So this is my friend Mark. It's an actual friend of mine. It's not a stock image from Google or anything. But this is my friend Mark. Mark runs Wild Birds Unlimited, and if you see, he's got a ton of pallets of bird seed and product that are in front of his office. It got deposited there on a Sunday. He had somebody in the office that couldn't load the stuff, so he had to go in, and he spent the whole day from like 8 in the morning until almost midnight loading all of this stuff in to into the store and relocating it and all this stuff. So there's tons of just lifting, and you can imagine the lifting and the twisting and the turning and all of the actions that he has to do throughout that whole day to get all this stock into the store. So he finishes all of that stuff. He goes home, has a good night's sleep, wakes up the next morning, and he's got pain. So he automatically thinks that everything is broken. He thinks that he's got like the worst case scenario and it's just terrible. So he's stressed out, he's frustrated, he doesn't understand what's happened. He's got all this pain that goes down into his glutes and his low back and his legs, and he thinks it's just terrible. And the one thing that we all know about pain is that you're just seeing the tip of the iceberg when you see a patient, and that there's a ton of underlying uh, things and factors that are contributing to their discomfort or their experience with pain. So why am I here today? Well, I'm here to improve your competence and your confidence in treating your patients that come to us with various forms of discomfort and pain. And pain might not be the right term that gets used for them. So it's always important to ask them, is there a different term that they would prefer to use? Um, there's a ton of different types of patients that walk into our office. The same patient that you see is not the same patient that you treated the last time. They're completely different. So, we spend the majority of our days going like, I don't even know what I'm doing with this patient. Like, am I doing anything right? Am I doing anything wrong? Am I going to hurt this patient? Like, what is supporting my actions as a clinician with this patient? Do I use this technique? Do I say this word? So it's just always just what am I even doing with this person? And a lot of therapists that I've talked to, when we have these conversations, they're very stressed. They have a lot of confidence in their ability to put hands on a patient and do some type of technique or treatment. But really, a lot of the times, there's a lot of insecurity and not a lot of self-confidence about what they're capable of helping this patient with, or how do I improve my outcomes? I have a lot of patients where I've worked on them and things haven't gone well at all. They've gone wrong. So what are the answers to these? So we've got 7 effects of treatment that we're going to talk about, and you're going to find out what these 7 effects are at the end of the presentation. And we've got the top 5 questions that every patient wants answers to. And this is every patient that you've ever seen in your whole practice, despite what kind of pathology or injury that they're coming in with, whatever the reason is, these are the top 5. So I hope to transform how you approach your patients with injuries and conditions and concerns, and how to think differently about pain and rehab management. I'm going to provide information you can immediately apply into your practice. And we're going to review a bunch of research pertaining to discomfort, dysfunctions of the joint tissues and conditions, and their referral patterns. And hopefully at the end of this presentation, you'll have a little bit more competence and confidence. You'll feel a little bit calmer in your treatment room with your patients, and you'll feel like you have some strength and some solid groundness to provide information to them. So most of our patients are having an amazing time. They're living their best life. They're having an amazing day. something goes wrong. Something comes into their life, it changes the direction that they were going on, and they're coming to us in order to try and calm the seas or get them back to some life that resembled what they had beforehand. So we're going to review a little bit of some anatomy and some physiology. So this is from my good friend, Robert Schleip. Robert Schleip is the head of the Fascia Research Congresses. So when talking to him about joint capsules and ligamentous tissues, he perceives them as just different densities with specific functions. So ligaments and joint capsules are now seen not as completely separate structures, but they are embedded local densifications, local specifications of a body-wide collagenous, fibrous, mostly tension-driven, interconnected system. You can't say that in one breath. And that is from the Fascia and Sports Medicine research DVD that he put out a number of years ago. So you can think of ligaments as just different types of pads. We've got a cotton pad, we've got a toning cloth, we've got a cotton ball, and they're just different densities with specific functions. And sometimes the cotton balls are happy and sometimes they're kind of cranky. So how ligamentous injuries happen, I want you to think about them as you're trying to pull a piece of cotton apart from the cotton ball. That's how I perceive ligaments. So they have sensory properties and they have mechanical properties. So the sensory properties, how ligaments are injured, is that they have a high frequency repetitive motion or sports activity. So we have creep, stress relaxation, and hysteresis. And then we have fast stretch. So you can think of your repetitive motions as basically that. It's your repetitive motions, your regular activities of daily living. Your fast stretch would be your ankle sprain. We also have our full contact gardeners. And I have a ton of full contact gardeners because they like to go out into the garden. They know that it's going to rain 2 days from now, so they have to get as much done as they can. And what do? They lift and they twist and they turn and they move things around and they lift heavy pots. And they do that for about 8 hours. And then they go to sleep. They wake up the next day, they do it all over again. And then they come into our offices and they don't understand why they've got this discomfort or this pain or this dysfunction in their low back. We've also got full contact shoveling, and I've got my full contact knitters. Yes, knitting is a full contact sport. I have patients that have severe neck and upper thorax injuries from full contact knitting. So it's a debilitating activity that I think everybody should just immediately stop. This is a video. I love this video, and this is of a high impact stretch. I love the shotgun sound. Like if you look at this, the distal end of his tibia and fibula are in contact with the earth. That's just amazing. Like he's fully planting that distal tib and fib into the earth. This is one of the Williams sisters.
Let's watch the left ankle here.
So you can see that there's that inversion sprain that's happening on that left ankle.
Let's watch the left ankle here.
Gotta go to here. Okay, so we've got normal crimped fibers. We've got a normal deformation, straightening of the fibers that happens in the ligaments. We've got a little bit of deformation and microscopic failure that happens around a yield point in the stress strain curve. And then we've got a complete tissue rupture that happens. So this is a stress strain curve. This is an image that I have on my TV. I've got a TV in my office. I've got it up on the wall. This image never leaves my screen because it defines what every patient comes in with. My full contact gardeners, they tend to live in the Goldilocks zone for the first few hours, but then they get into the failure zone. They don't go into complete tissue rupture, but they're living in that failure zone area where they're they're slowly increasing a number of inflammatory, pro-inflammatory cytokine mediators throughout their whole throughout their tissues. And we're going to go a little bit into some research about how long it takes typically for this to heal. But with my full contact gardeners, and my full contact knitters, they're all living in this failure zone. Really, we'd like them to have a bit more rest periods, live in the yield zone so that they can break down some tissue, have some rest, allow the tissue to recuperate and build back up again. But they're all living in this failure zone. So we're going to talk a little bit about wound healing. Typically, tissue, there's a bleeding or an inflammatory phase. It lasts about 2 to 6 weeks. It occurs within hours. It can last for weeks. There's usually a neovascularization and granular tissue that forms. There's a cell proliferation that lasts weeks to months. So this timeline is getting longer with the healing process. Again, fibroblasts are recruited to produce matrix and create some new tissue. And then we've got matrix remodeling phase. This continues months to years. So we never learn that it takes years for tissue to heal. We always learn that, acute, subacute, and chronic, you've got 4 weeks, 4 to 6 weeks, 6 to 8 weeks, you're chronic, and then you're done. Everything's back to normal. It should be healed. It should be fine. And that's just simply not the case according to research. This is from Susan Chappell, a great RMT, an amazing friend of mine. This is from her book. So we're looking at tendon and ligament injury and healing times, potential therapeutic opportunities. So they suggest that mobilization of tendons and sheets and mobilization of ligamentous tissues not happen until the remodeling stage, which is about 3 to 6 weeks into the healing timeline. I have a different perspective on that, and I prefer that the mobilization of tendons and ligamentous tissues happens immediately within, if you can do it within 72 hours, if you can get your hands on post-surgical tissue or acutely injured tissue as soon as possible. In my practice over the last 30 years, and from friends of mine that have had similar practices, our experiences that our outcomes are far greater than if we were to wait for 3 to 6 weeks and wait for all of that tissue to get laid down. I want you to think about adhesions and scar tissues as being an egg white. So in the early days, it's an egg white consistency. In the later weeks, it becomes a blue gene consistency. So you can't break it down with your hands. You can't break it down with your, instrument assisted soft tissue tools. You want to get your hands on that egg white consistency as soon as possible because we have influence. We have the ability to mold it and shape it and encourage it to be in a position to provide an increased amount of function, as it solidifies in place. I'm a example of that. I had a motor vehicle accident in November of 2018. I had, if you want to talk about pain in the thorax, I had from rib 1 through 6 sternochondral joints were comminuted fractures. So comminuted fractures, take potato chip, you smash it up, you get a whole bunch of crumbs. That's what all of these joints looked like. The same with the costochondral and the costovertebral joints from T1 to T10, all crushed. I checked myself out of the emergency room the night of the accident, despite the EMTs and the emergency doctor's recommendations. They were going to keep me overnight. I was like, nope, I'm going home. And I started stretching immediately the first night. My wife thought that I was absolutely crazy. Was it painful? Absolutely. But in doing that, in knowing that those type 2 collagen fibers were being laid down within the first 2 to 8 hours, and that I wanted to mold that egg white consistency so I'd have full function later on, I have full function with my shoulder, my thorax. I've got discomfort and pain, but I've got full function. So my suggestion to you is get your hands on acute injuries, acute pathologies, post-surgical as soon as possible. And obviously using some common sense and informed consent with your patients, try and get as much work done as you can with those people. So this is what a normal ligament looks like, and this is what an adhesion looks like in ligamentous tissue that hasn't been mobilized. We've got tendinous tissue that shows no mobilization compared to a tendinous tissue that had early mobilization. So you can see that the structure and the function of the tissue is completely different. Ligaments as a source of work-related musculoskeletal disorders. This is from Moshe Solomono. With acute inflammation, it sets within 2 hours. His research shows that acute inflammation can last up to 12 months. So your timelines for acute, subacute, and chronic are now completely wiped out. They don't exist any longer. It depends on the patient. It depends on the injury. It depends on so many other factors. And his research showed that only 70% of the original structure and functional characteristics were ever obtained. So your acute timelines are a little bit longer than 2 to 4 weeks now. Chronic has shown to never fully recuperate, and chronic can last weeks, months, or years. Recovery. So when I talk about my full contact gardeners and we have that stress strain curve, and we talk about the fact that they've been living in that failure zone, and they did full contact gardening for 8 hours, and then they did another 8 hours the next day, the rule for recovery is that it takes 20 to 40 times longer than what the actual time spent doing the activity is. So for every hour that they spend doing full contact gardening, it's typically about 48 hours before they start to feel better. So if they've done 16 hours of full contact gardening, you're looking at a minimum of 6 to 8 weeks before they start to feel better, before we start to see the decrease in protective mechanisms through their musculature. We start to see increases in range of motion through the vertebral column or the joint, that whatever joint you're working on. So when I explain this to them, it removes questioning, it removes frustration, it providing information to them and education. It actually calms them down. We get a lot of patients that will come to us and they'll say, I don't understand why I'm not fixed yet. I don't understand why you haven't fixed me yet. It's like, well, for one, we don't use the F word. We don't fix anything in our practice. And for two, time is a factor that no one factors into the equation of healing. So if we're only 2 weeks into an 8-week process, then we're still in the process. We still have time to work with the tissue. And providing that they don't do anything later or during that time to re-injure or spike the acute phase again, then it might take longer. So it's just nice to have this information to settle everybody down, provide some calmness in the room. So again, full contact gardening, for every hour of creep tension relaxation, you're looking at 2 days minimum required for recovery. Okay, so ligaments are adaptive. They respond to increased physical activity and inactivity. Moderate exercise with sufficient rest and recovery is always recommended. We want to make sure that they're not immobilizing or reducing their physical activities. We want to maintain their strength, coordination, agility, proprioception. We want to make sure that they've got good balance, coordination, so on and so forth. We want to make sure that they're not going through an atrophy sort of phase. So some research. So I've done 3 research projects. I'm just writing the papers right now. So we're going to run through some of that. So everybody remembers in school learning the dermatome and the myotome dance. And does everybody remember what a dermatome and a myotome is? So a dermatome and a dermatome is an area of skin that is innervated by a peripheral nerve that comes from a specific nerve root. And a myotome is a muscle or a muscle group that's innervated by a peripheral nerve that comes from a specific nerve root. But I thought about, well, what about the joint capsules ligamentous tissues? Like, we know that they have mechanoreceptors in them, but how does the information get from the mechanoreceptor to the spinal cord and then get perceived as whatever sensation through the sensory cortex? So I went through and I found all the research, and it was incredibly difficult to find because it's not out there in your face. You actually have to go and buy textbooks from, the New York School of Anesthesiology. It was a $400 textbook. So this information isn't information that's widely available to naturopaths, chiros, physios, massage therapists. But if you're going into anesthesiology, it's all there. So my posit to everybody is that these are going to be called arthrotomes. So this is a joint capsule ligamentous tissue that's mainly supplied by a peripheral nerve coming from a specific nerve root. So I've gone through every joint capsule ligamentous tissue for the whole body, and we have been able to identify the peripheral nerve that innervates every joint capsule ligamentous tissue and the nerve root that peripheral nerve comes from. So we've done it for cervical, thoracic, lumbar spine, and we've done it for every joint in the peripheral skeletal system. So for example, cervical spine, these are your nerve roots, your peripheral nerves, and the tissues that innervate the joint capsule ligamentous tissues that are innervated. We've done it for the shoulder also. So for example, C3 and C5 for the medial supraclavicular nerve, they innervate anterior posterior sternoclavicular ligament, the interclavicular ligament, the costoclavicular ligament, and the sternoclavicular fibrous capsule. And this is all documented research. So we've done this for the whole axial and peripheral spine. So for example, there's your supraclavicular nerve innervating the sternoclavicular ligamentous tissue, interclavicular ligament. We've got the peripheral nerve going to the dorsal root ganglion, and then we've got all of the nerves along thoracic nerve, the intercostal nerves from ribs 1 to 7, T1 to 7, that innervate the ribs, the joint tissues, the periosteum, the manubrium, the sternum, so on and so forth. And I hired a anatomy illustrator, and he was able to illustrate everything as per what the research had documented for the peripheral nerves for the joint tissues. There's also a ligamentomuscular reflex that occurs. So when you challenge a joint tissue, a ligament or a joint capsule, there's a signal that is sent immediately to the musculature around the tissue to protect and guard and provide stability through the area. It actually so it all starts with the mechanoreceptors, which you've seen previously. So you got your type 1, 2, 3, and 4 mechanoreceptors. We've got a monosynaptic and a polysynaptic pathway that this ligamentomuscular reflex occurs through. The mechanism is that there's an afferent information, there is a reflex muscle inhibition or stimulation. So in research, it's talked about as arthrogenic muscular inhibition, but there's also a stimulation that occurs too in certain tissues. There's a change in the somatosensory cortex, there's an increased resilience for other cortical areas, and then there's a decreased descending motor output. So you can feel like you've got less motor control, or sometimes it'll feel like the muscle tissue is actually tightened and hypertonic and always hypertensive. So an example would be, this is going for the sciatic nerve. So we've got your mechanoreceptors. They go through the posterior articular branches of the knee. It goes through the tibial nerve, sciatic nerve, all the way through the spinal cord, and synapses into the primary somatosensory cortex. And then we have the primary motor cortex coming down through the spinal cord and then coming out through L5 all the way down to S1 and S2 to cause the contraction of that musculature. And then we've gone through and documented all of the ligamentomuscular reflexes and the actions that occur in the documented research for each of those joint capsule ligamentous tissues. Just thinking about this for a second, you've probably had patients come into your practice that have had a foosh, a fall on an outstretched hand, and they've said to you, I don't remember doing anything to my elbow. I know that it landed on my wrist, but like it's been about 6 or 8 months, and my elbow, I just got diagnosed with like tennis elbow or golfer's elbow, and I don't understand why, because I don't play tennis and I don't golf, and I didn't really do anything there. Can why did that happen? Well, what we know is that there is a little ligament called your scapholunate interosseous ligamentous tissue that gets sprained and it becomes dysfunctional in through the wrist. And when that ligament becomes dysfunctional, it creates a co-contraction of the common extensor, common flexor muscles of the forearm to try and stabilize that joint. So these become overworked and underpaid and hypertensive and hypersensitized, and then suddenly you develop your tennis elbow, your golfer's elbow, or your medial lateral epicondylitis. So rather than, what most therapists do is they go and they treat the living crap out of the forearm and the elbow, and it never gets better. It's just a constant chronic complaint that the patient is always coming back with, but they've never gone down and they've never treated the wrist. Now, if they were to go down and treat the wrist appropriately, you'd probably find that the outcomes for the forearm would be a lot better. Pain referral patterns. So there are specific pain referral patterns for the joint capsule ligamentous tissues of the spinal column, and the axial column, and the peripheral joint tissues. So we've gone through and we've documented all of those and all of the different ways that pain referral happens in the body. And when I've asked this question, nationally and internationally, locally, to a number of different, clinicians and therapists, how does referred pain happen? It's amazing the amount of Disney bedtime stories that get thrown out. It's all in the fascia, or it's all in your head, or it's all in lymphatics, or it's all in the whatever, and none of it's ever correct. So there are actually four main reasons or theories as to why referred pain occurs. So the first one is the neuroanatomical framework for pain referral pain mechanisms. So we have a repetitive loading and a fast stretch that goes through this whole series of events that leads to increased muscle stiffness, which then ends up causing central sensitization and peripheral sensitization, which leads to the experience of pain and the experience of referred pain. So this is one theory of how referred pain happens. The next is the neurophysiological model for referred pain. This happens through the dorsal root ganglions. So if we do something to the glenohumeral joint tissue, we now know that that's innervated. We have the peripheral nerve and the dorsal root ganglion that innervates that joint tissue. And when we do something to the tissue, that peripheral nerve and the dorsal root ganglion, the primary dorsal root ganglion, it gets inflamed and pissed off and cranky and overworked and underpaid. And you get a little cytokine inflammatory storm that surrounds that dorsal root ganglion. That inflammatory cytokine mediator storm, it actually migrates between 3 and 6 levels. So now you will have a dorsal root ganglion that was primarily involved, but then 5 layers down, you have a different dorsal root ganglion that was just minding its own business, just happy living its best life. And suddenly now it's getting pissed off because everything is migrating down. It innervates completely different tissue. So now that tissue feels like it's uncomfortable, it's painful, they're having some type of discomfort or pain experience. So that's the neurophysiological model for referred pain. So there's 7 features of this model. It's felt distant to the initial local pain. It's semi-directional. It's a deeper sensation. It needs a higher stimulus than the local pain, which means you can go and you can, if you've done something to your shoulder and the referred pain is in the wrist, if you go and you touch the wrist doesn't hurt. It's delayed. It's delayed because it takes time for that inflammatory cytokine soup to grow. It diminishes before because it sort of recedes. And then it's also another example of how phantom limb pain can occur, because even though the limb has been amputated, the peripheral nerve and the dorsal root ganglion are still there. We have a convergence projection theory. So this is new stuff that I've come into contact with. So we're looking at the subthreshold sensory input from cutaneous receptors or joint tissues. In the lower limb, they synapse onto the same spinal thalamic cell body as an input into the cinevertebral nerve. And then when a suprathreshold pain stimulus occurs, pain is referred to the leg. There's a convergence projection pattern. So we have a change in innervation that you can see down where the arrow in the spinal cord is, where it was innervated here. Now it's been changed and it's innervated there. So the information is then projected to the sensory cortex, where pain is perceived as originating from the leg when it's not. And then we have the reflex pathway, where now it feels like it's being projected into a different area of the body altogether. And then we have the neurophysiological schematic model for dichotomizing afferent fibers. So dichotomizing afferent fibers is that you have a bunch of fibers from all over the place, kind of like your old telephone operators, connection cord circuit board with all these wires and things going in different directions, but all disconnecting and connecting into different areas. So it kind of gets a mixed signal, and you get a mixed sense of where this referred pain is sort of coming from. So those are the three research projects that I did, and I'm just writing the papers for it now. So factors affecting wound healing. We know that our thoughts, beliefs, and expectations play a huge role into the body's ability to heal. We know that this is from Lorimer Moseley. We know that when we experience pain, our credible evidence of danger is greater than our credible evidence of safety. And equally, we won't have pain when our credible evidence of safety is greater than our credible evidence of danger. We have DIMS and SIMS. So DIMS and SIMS stand for dangers in me and safety in me. I have this, again, this is another slide that I have up on the screen in my office, because we have a lot of patients that were doing an action, something happened, they felt like they got injured. In their mind, that action that they had done for a long period of time is now dangerous, and they don't want to do it because they don't want to run the risk of re-injury. So then they stop doing it. Now, that activity could be something that they love to do, that now they are fearful of doing. So this is an image that stimulates a conversation around danger and safety and actions and thoughts, beliefs, and expectations. So it's a communication influencer and stimulator for us with our patients. We have the imprecision hypothesis, where we have a person who was had a dog bite. It's a very terrible experience. There was blood, there may have been stitches, just a negative experience for the person. You show them a picture of a cute puppy dog sleeping in a bed, and it's just a picture. It's not a real puppy dog, it's just a picture of a puppy dog. That person will experience the exact same thoughts, beliefs, expectations, emotions, sensations as if the attack was happening again. So we always think of our bodies as protecting and serving us, but really a lot of the times our patients will say, I feel like I'm just being punished and enslaved. Like I feel like I'm in jail. I can't go out. I can't do things. I used to like to go and do this stuff, but now I can't. If you really want to get into the deep dive research into factors affecting wound healing, then you get into the dental research, because those guys are causing harm every day with every patient. And they've got a ton of information around the psychological stress factors that contribute to impaired wound healing. Brain mechanisms for chronic pain. This is from Dr. Ipkarian at the San Diego Pain Conference a number of years ago. So this is looking at brain changes that occur in patients where the pain has resolved or where the pain has persisted. So for the patients that have resolved, that's the SBPR, so the pain is resolved, you can see that the primary sensory cortex and the emotional centers, they sort of light up for the first few weeks, but then as it gets into chronic, they rehab properly, or everything goes well for them, and they have no more discomfort, no more dysfunction afterwards. So there's nothing that lights up on their brain scans. On the patients where the pain is persisted, you can see that it actually changes from sensory cortex into more of the emotional centers. So this is your medial prefrontal cortex and those sorts of areas. So it actually you can prolong the pain experience and the discomfort experience by just thinking that you're never going, by having those negative thoughts, those unpositive thoughts, where you're never going to get healed, you're always damaged, you're always going to be in pain, nothing is ever going to go well for you, sort of that closed mindset. So we have this armoring and protection that happens. We have a ligament muscular reflex. We've got chronic fascial stiffness from the musculature that constricts around the vasculature. And then we've got these neuroplastic changes that take place in the brain and the spinal cord that will contribute to the prolongedness of this pain and this discomfort. So we've got these neuroplastic changes that really they are more determining factors for the transition from acute to chronic than tissue rebuilding is. And we've gone from nociceptive to nociplastic pain experiences. So we've got our patients that are always, stressful, and they're not calm, and they don't know what to do, and they're very depressed. So for treatment, what do we do with this mess of this person that's in front of us? And we've had these people where they are a brand new patient to you. They've been to see everybody. I've been to see the best. I've been to see everybody, but my girlfriend or my friend, they recommended that you were the one. You were awesome with them. They had an amazing experience. So I've got this whole life where I've got all this horribleness that's happened, and now I'm here. So what are you going to do for me? Have we ever had that before? I've had that a ton of times. So what do we include in our treatment? Well, we've got treatment context and we've got treatment content that we have to think about. We have to recognize that our words, our terminology, the stories that we tell, the narratives that we use, our verbal influences all have an amazing impact into our patients. And you might just use a term that you think is completely innocuous, but it sends that patient down a deep dive spiral into depression, that you never intended, but it's that one term that they just perceived differently than how it was intended. So sometimes words hurt more. Words create worlds. And we have a bunch of research about the neuroplastic changes from therapists using top-down and bottom-up influences. So our top-down or our bottom-up influences are manual therapy, motor learning, peripheral sensory stimulation, activity. Our top-down influences are our education, our terminology, our narratives, our CBT, cognitive behavioral therapy, mindfulness, meditation, motor imaging. And when we utilize both top-down and bottom-up influences at the same time, that's when we tend to see really, really amazing positive outcomes with our patients. So we don't use words like bad posture or slip disc or hypermobile or worn down or wear and tear. A patient of mine actually the other day was talking about wear and tear with her hip pain and osteoarthritis. And she said, yeah, this wear and tear is really terrible for us. It really sucks getting old. And I said, it's really interesting you talk about wear and tear, because I've got a female world-class power lifter. She's about 6'6", and she's about 300 pounds. And she regularly squats, 400 or 500 pounds. She regularly deadlifts, 800-900 pounds on a regular basis. It's a lot of wear, isn't it? She doesn't have any tear. She's got a lot of repair happening. So we prefer to use wear and repair rather than wear and tear these days. So we have a lot of terms that we don't use. I've had a lot of female patients that come in and they're very embarrassed and they feel depressed, and there's been emotional, psychological changes because they've had some type of scar somewhere in their body, either from breast reduction or breast augmentation or breast removal or C-section or post-surgical somewhere. And they come in and they're in that mental emotional state of just, depression. And I look at them, I say, oh, scars are awesome. They're like, what do you mean scars are awesome? This thing has changed my life. It's horrible. It's like, no, scars, we like scars. Scars are great because they stand for, strong, capable, adaptable, and resilient. And that's what you are. You're strong, capable, adaptable, and resilient. You've gone through all of this stuff and you now have this. It's sort of a badge of honor in some ways. And just having that sort of that change in perception with your patients is important. So is it always pain or is it something else? A lot of patients are always using the term pain, but they're using it because that's what's been used at them. It's what their physician has used, it's what their physios use, or another massage therapist, or another medical clinician, or a girlfriend, or a friend, or somebody in the community. You always get asked about your pain level. Well, what if it's not pain? What if it's something else? What if it's numbness, tingling, pins and needles, burning? What if it's a lack of sensation? What if it's aldynia, hyperalgesia? What is it? So we always know that we've got patients that have come from somewhere and they've got a destination that they want to get to. So I used to have this amazing life. I'd like to get back to some kind of semblance of that. So I'm always asking them, where would you like to go? Where would you like to go on vacation? Um, I'm gonna skip through a bunch of stuff here because we are moving on with time, and I want to get back to my friend Mark. So remember Mark, he had gone into work on the Sunday and he lifted all the pallets of the bird seed and all of the store stock, and he woke up the next morning and he had a whole bunch of pain. So what does Mark do? He gets on Dr. Google and he starts Dr. Googling everything. And at that point, it's just like, oh my God, it's a tumor. No, it's not the tumor. It's a tumor, or it's cancer, or it's a slip disc. My disc popped out. I've got, degenerative joint disease. I've got these osteophytes. I don't even know what those things are. I've probably got osteoarthritis, and I've got all the horribleness that he never knew that he always had. Now he has it and he thinks that everything is just terrible. So again, he's stressed out, and him and his wife, they actually call me and say, hey, look at, here's this thing that happened, it's absolutely horrible, can we get you in? So we start having a chat about all of the things that we've just run through in this presentation. And he looks at me, he says, okay, well, you and I, we're both athletes, right? We both ride bikes. I actually competed as a triathlete for a number of years. This is a picture of me in Australia at Worlds in 2009. And Mark and I, we are both athletes. And he says, well, I guess with all of this pain and discomfort in my slip discs and all the terrible Dr. Google-ness that I've found out, I guess that I should really quit cycling because it's a bent over position and it's not good for my core and it's horrible, right? It's like, no, you actually want to continue activity. This is where our DIMS and our SIMs come into play. He now thinks that an activity that he used to love to do is now dangerous and that he doesn't want to do it any longer. When clearly we want him to do that. We want him to live his best life and be his best self and get out and enjoy activity and life. So again, we talk about the different types of terminologies and words and narratives that we talk about. We tell them that humans are robust and that they're anti-fragile beings. It's an incredibly strong system, this body. Your tissue has a tensile strength of 2,000 pounds per square inch at some places. Your IT band has a tensile strength of 8,000 pounds per square inch. You're not going to pull your IT band. So I tell them about all of the research, and we now think that everything is awesome. We talk about that the research that shows that physical activity should be the mainstay approach for management of depression, anxiety, psychological distress, and rehabilitation. We also talk about the research, the Hurt So Good Pain is an Emotional Regulation Strategy. So this research was amazing because it discusses, if you read the red line, we discuss the implication that benign physical pain may be a broadly effective and under-recognized coping strategy. So the term there, benign physical pain. So you're going to do something that's going to hurt, but it's going to be good for you. It's not going to cause damage, and it's not going to cause any type of hurt or negative things to your life. It's actually going to help your life. We also talk about the research for the relationship between physical activity and pain tolerance. There's been a ton of research that's come out that shows that the more active you are, the less discomfort and pain that you're going to experience. So this calms Mark down. We do some hands-on treatment, some appropriate hands-on treatment for him to help decrease, muscle guarding and discomfort, and we increase some joint fluid movement. We get some stretching and some activity involved in the table also. And Mark's a happy guy. His pain diminishes. He gets back to his normal life. It takes a little bit of time. Remember, that's the one factor that not a lot of people think about when they're rehabilitating. But he got back to normal and was taking Molly, the dog, out for walks, and he's, living his best life. So we always need to empower our patients. We need to provide them some education. We need to give them some baby steps for making positive actions in their rehab. Got to make sure that they get some manual therapy, because manual therapy is amazing. Got to be mindful of their thoughts, their beliefs, their expectations. Got to make sure they get a ton of sleep, because there's a ton of research into sleep and how it benefits us for rehab. And then we got to get them doing some activities that they find fun. I no longer, prescribe, a certain amount of sets and reps in a gym with barbells and dumbbells and free weights. It's like, what's an activity that you love to do? Let's get you doing that. So we want to create change and we want to facilitate growth. We want to think about that connective tissues and neuropsychophysiological dysfunctions cause reorganization of the central nervous system. So we want to make sure that we're getting the central nervous system to reorganize in the way that we want it to. And we want to get everybody to get back on their vacation. They all started out having a great day. Something bad happened, and now they're unsure of where they want to go. So we need to get them back on vacation. Okay, so at the beginning, I talked about the 7 effects of treatment. So these are the only effects of treatment that my patients ever expect from me. This is up on my wall. They come back and they tell me which one it is. It was worse later. There was no change. It was better, worse, no better, no worse, or better later. And then the top 5 questions. The top 5. Can you think about what the top 5 questions are that your patient, all of your patients, doesn't matter which kind of a patient it is, they all have these top 5 questions. What do you think those are?
When am I going to get better?
Okay.
Can I get better? Like, can I get back to 100% and how long?
Right. Well, let's run through these. So they want to know what's wrong with them. What's wrong with me? Well, now you know. You can describe to them all of the multifactorial components that has led to why they're in front of you. How long is it going to take? Well, now you have that information. Depending on how long they full contact gardened, it can, and what they do with their life depends on what their nutrition, their lifestyle, what, are they hydrated? Are they physically active? What are their thoughts, beliefs, and their expectations? So that all factors into the length of time that it's going to take to heal. What can the patient do about it? So we want them taking positive actions for themselves to build their confidence and competence in their abilities back up also. What can the clinician do? Well, we can tell them how awesome they are and how nice they are and that it's going to be great. In cases where there's a continual progressive degenerative process that's occurring, well, then we're going to be real about that. But we're always going to be able to find some positive aspects mixed in with sort of the weeds. And then what's it going to cost? Well, that depends. I have a number of patients that I have on sliding scales because they're social assistance welfare, they're on limited funds, they need treatment. So, if they can afford $1 a minute, well, then I have them come in and I treat them. So these are the top 5 questions that most patients have got. Hopefully this makes you a little bit more relaxed and a little bit more calm with your patients. You've got some answers that you can provide and some information and some education you can provide to your patients in order to calm them down also. So that is deconstructing the neuropsychophysiological nature of joint pain. So that's me.
Amazing. So much useful information in there. Thank you so much. That was power packed. There was so much in there.
Yeah,
Yeah.
there's a lot actually that I cut out.
Right.
But
Just for the
it's
sake of time.
but I wanted to, everybody's got this amazing education that we had, they've got from just graduating or that we had, 30 plus years ago. And some people have kept up with it, some people haven't. Some of this stuff wasn't presented in school or through their formal education at all. A lot of this stuff is brand new. So these are current conversations that are happening in pain science Facebook pages globally with amazing global physicians. I gotta say, like, I've benefited so much from just sitting back and watching conversations happening, and I've learned so much from those. So I really wanted to get that into this also.
Yeah, amazing. And the advancements of people understanding how things work together now. And in our previous understandings, people were always trying to take things apart and look at them individually and separately. And now the new understanding is revolves so much more around how are things interconnected? How are things relating to each other? How do they, play off one another or enhance one another? And what you're doing with the joint capsules and the ligaments and the nerve roots and how they're all connected. I mean, that's so amazing. I have a question for you, if that's okay.
Yeah. Just on that,
So,
just on that,
oh yeah.
everything being
Mhm.
separate, like when we went through school and still how they teach it now, globally in medical curricula, they still separate systems. They separate the nervous system from the vascular system, from the lymphatic system, from the muscular system, from the joint capsule ligamentous tissues. And they're not separate. They don't work in parallel. They work in series with each other. And they're just different densities with specific functions. The liver doesn't know that it's called a liver. It's just a different density of organic matter that has a specific function that's different from a pancreas or a muscle or anything else.
Amazing. Yeah, for sure. Now, one of the questions that I had was in your relation to the 20 to 40 times longer to recover from the activity that caused the injury. Thinking about breast and chest surgery, some of them are faster, some of them are extensive. So is that the same kind of rule of thumb for surgery as it is for the mechanism of injury, like your contact gardeners?
I think with that stuff, I think remembering that in the early days, the fibroblasts and the rebuilding the type 2 collagens, type 1 collagens, they're in that egg white sort of consistency state. And
Mhm.
really, really important, not just for us to get hands-on in order to create the sliding and the gliding and create those serious uh, fluid sort of dynamics in order to create sort of some viscosity, between the tissues. But I think it's really important for the patient to move also, and to take advantage of that opportunity of influencing the elasticity and the plasticity of that egg white. So I tend to come to it from that. As far as timelines go, it depends on the person, what and who they were beforehand. Were they physically active? What was their nutrition like? Um, you know, so many different factors.
Yeah, so many different factors. But I think I was thinking, some surgeries take like 45 minutes, maybe 90 minutes. Some surgeries take 10 hours, and that it's a lot more extensive. And what the body has to go through in order to be able to heal after such extensive surgery.
Yeah,
If it, obviously it's going to take longer. A 10-hour surgery, they're just doing so much more in the body. So obviously it's going to take longer to heal than something that's, maybe 90 minutes. So, but I was wondering if that kind of rule of thumb for the mechanism of injury is because surgery is a controlled environment. It's different than, someone who's out doing their contact gardening, which
yeah,
by the way, I love the term.
I think
It's
the
just
timeline's sort of a sliding scale.
right.
I've had patients that have gone in for, a knee surgery, and it's taken them a year to recovery. And I've had somebody with a completely different lifestyle, a more active lifestyle, a better nutrition and better psychological perspectives and emotional perspectives on it. And they were back to, walking and running and doing a whole bunch of different things within 8 weeks.
Yeah.
So I think
Mhm.
it's an n equals one sort of a sort of thing. And yeah, I think that's it's kind of a sliding scale.
Yeah, yeah, for sure. And people's beliefs, like you were talking about, with how their beliefs can influence their healing. And I really love the slide that you had up there of the emotional um, pain patterns in the brain around their beliefs in healing, and whether they're doing like catastrophic thinking or whether they're kind of on board, like, okay, we can get through this. This is okay. And the signals that were created in the brain over, well into the chronic phase of healing, dependent upon what their beliefs around healing are. That's super fascinating and very applicable to this population.
That was an amazing video to watch. So that's from San Diego Pain Summit. I think might be San Diego Pain Summit 2016, 17, or 18. So Dr. Abe Carrion is a neuroscientist. He works in the lab, and he's giving this presentation to all of the members that showed up for the San Diego Pain Summit. And so there's massage therapists and physios and chiros and physical activity professionals and personal trainers um, and somebody puts their hand up and says, well, when you were doing your research, did you factor in any type of, what we do, any type of manual therapy or things like that? He's like, yeah, we looked at that, but it really wasn't significant.
I don't know if I agree with that.
Everybody's like, what? It's not significant. He's like, well, it had an impact, but it didn't really skew our results in any way, shape, or form. So,
Mm,
so no, we didn't really see what you guys did as being influential.
mm.
Hmm.
I don't know the
What?
lens. Yeah, I feel like
So again, it's
maybe
one of
looking
those
through a
things
different
where,
lens.
yeah, it's one of those things where it's like, okay, well, we don't know what was being done in the clinic room. We don't know what was being said. We don't know anything. We don't know anything. We don't know what the influences were, and so on and so forth. So I know that, and you guys have probably got the experience in your practice also, where you've got somebody that's come to you with this chronic, long-standing discomfort and dysfunction, and you have one treatment with them that was just the universe-changing treatment, and they walk out bouncing like a tiger.
Hmm.
I have this story where I have an 8,000-year-old Chinese guy who, and this is true, he's a patient of mine, and he likes to teach Tai Chi. And he has something happen. He's in his 80s. So he has something happen to his shoulder. It hurts. He goes and he sees somebody else, physio or massage. They tell him how horrible it is and that he has the frozen shoulder. So he comes to me, we run through all the exams, we do our due diligence, we do our neurological and our orthopedic assessment. He doesn't have frozen shoulder, he has cranky shoulder. So we put him on the table. I start telling him how awesome his shoulder is and how amazing the tissue is and the pliability and the elasticity. And I'm moving his shoulder in all the ranges, and I'm like loading the living crap out of this thing. And I'm like, dude, you have the shoulder of a 19-year-old. He's like, what? I was told that it was horrible. I'm like, no, this is the best shoulder I've seen all day.
Mm.
He's like, tell me more about how awesome I am. And 3 treatments, don't need to see him anymore. Like, come on.
Yeah, narrative is powerful for sure. The words we use are powerful. How we show up as therapists is powerful. What we bring to the table in terms of the therapeutic relationship is very influential.
Absolutely.
And yeah, if we take a more collaborative approach to healing, like what we're bringing, what you're bringing, how that's interacting together, I think it creates a very different experience than the kind of authoritarian, I'm going to tell you what's happening, you're going to listen to me, you're needing fixing because you're broken in some way, and I'm going to be the one to come in and save you. Like, it's a very different environment and creates very different healing outcomes for the patients.
Yeah. You have
Yeah.
to, you're not the most important person in the room. when a patient comes in. And
Mhm.
we get a lot of, I've seen a lot of discussions on the social media forums about, you know, what do I do with this patient? They didn't treat me really nice. They treated me like shit. They called me down, blah, blah, blah. If I have a patient that's coming into me, I always take a good 10, 15 minutes and we have a conversation. I want to get a read on them. I want to know, you know, is it safe to provide treatment to them? Is it safe for me to provide treatment to them? Like, do I feel safe in the room? I want to make sure that we both feel safe and comfortable in the room. And when I've had patients come in and they're off, like they're cranky and they're pissed off and they're swearing, and there may have been a couple of jabs sent towards my direction. I'm I'm not going to take it personally. I'm going to actually be more interested in what's going on with that patient. Like what's going on with you? Are you okay? Like we don't have to do this today, but I'm concerned with with your safety, right? Put it
Mhm.
back on them. They're the most important person in the room, and then things switch.
Mhm. Mhm. That's the human-centric care where you're responding to the person and not the condition as primary. Yeah,
Exactly.
so important. Well, amazing. This has been so fun and so informative. Congratulations on all the mapping out and the connecting that you did from the nerve roots to all creating the arthrotomes and, getting all that information out there. So it's not just reserved for a very small part of the population. It's really, really important work and you're advancing people's knowledge in such a great way. So I'm so thrilled that you were able to come and share some of your insights with us. This is going to go out to all our channels, which is about 3,000 people at the moment. So thank you very much for being with us today. I hope anyone else who wants to take Robert's courses, they're so good. They're so well researched. They're very informative. They've got lots of practical application. I still use his things that I learned, I don't know, 14, 15 years ago.
My God.
And yeah, there's lots of really good nuggets that it comes in all of his courses. So ligamentous articular strain technique
I'm going
is
to do a little. I'm going to do a little shameless plug. So for
yeah, do it.
information on the arthrotomes and neurological innervations, nerve root, peripheral nerve, joint capsule tissues, ligamentpain.com. So I wrote a book, Ligament Pain Referral Patterns, and for example, for the shoulder, we've got all of the neurological innervations and then the image to go along with the research. The thing with the
Amazing.
images with my anatomy illustrator was that the research would say that a nerve goes this way and then attaches into the tissue. And he's in Romania, so we're on a time delay. And he would send me an image where the nerve went this way. And for every nerve, we would have to go back and forth going, no, it goes this way. It doesn't go that way. So it was very surgical to go through all of the nerves, as per what the research described, how they went. Now we know that this is a variable sort of form, but I wanted to get it, I wanted to do the research justice. So that's where the images come from. So that's all at
Amazing.
ligamentpain.com.
Ligamentpain.com. Amazing. Thank you so much. So have a wonderful rest of your day. I hope that this is fruitful for you. I know it's fruitful for all the people who are going to be listening to this in the times to come. Yeah,
I'm going to treat a full day of patients now.
amazing. Thank you for your time. We'll talk to you later.
All right. Thanks, guys.
Bye.
Bye.